And here's just a picture to demonstrate it. It's very that goes into the nose to the back of the throat. And they'll send it for a genetic material for the virus. So if the swab is positive, then we know for sure that you have COVID-19. However, if the swab is negative, there's very rare instances where it can be negative, a false negative. What that means is the swab is negative, but you do have COVID-19. Again, this is very rare, but the main instances where I've seen this happen is based on the quality of the specimen, where it usually, if it didn't go far back enough into the throat or it didn't stay long enough. So in case that happens, what we usually do is try to collect another sample. We know for sure that the nasopharyngeal swab is better than the throat swab, but then the anything samples from the lungs is usually better. So that means if they're able to cough anything up, we'll send the sputum or the virus as well. What usually happens in the hospital setting is if we have a high clinical suspicion that this is COVID-19, but their first swab is negative, then we will consider testing the swab again or send a sputum sample. I just want to emphasize that everything I talked about so far is about testing in the hospital setting. So this is not, does not relate to testing in the community setting. So in the hospital setting, it's where the doctors will assess the patient and make that decision. However, for the people at home, what I recommend to do if you are exposed to COVID or have any symptoms is you go on the online website, as I outlined here, which is an online COVID-19 self-assessment tool by the Ministry of Health, Ontario. And that tool will ask you what sort of symptoms you have and then tell you what to do based on the symptoms that you have, whether it's to remain at home, to get testing, or seek medical attention. So now I want to move on to management of COVID-19. So the management that we do in the hospital is based on already published, established guidelines. We have a guidelines already published in Canada that was published on April the 2nd, as well as guidelines published from the US, which is published in April 11th. So I just had the reference down below. If you want to check it out, it's free to the public. So across all those guidelines, what I want to emphasize is that the recommendations have been very consistent. And what we focus on in the hospital setting for treatment is mainly supportive care. And what I again want to emphasize is there's no COVID-19 specific therapies that's recommended currently outside of clinical trials. So the best way to think about management is to consider the spectrum of disease for COVID-19. The most useful way, in my opinion, to categorize it is to split COVID-19 infection into 3 categories. So as you see here from left to right, you have the mild disease, the severe pneumonia, and also the critically ill. So the percentages I had here, it's based on a large study coming from Wuhan, China, that had more than 70,000 cases. And then the clinical presentations, it's based on the Canadian guidelines. And then the management for the corresponding severity, it's also based on the Canadian guidelines. So just going from left to right, we're going to start with mild disease. And this is going to be in the majority of patients. So going to be in 81% of the cases. What you're going to have is very mild symptoms, almost like a common cold or very mild pneumonia. So in those cases, the infection will resolve by itself and you do not need any treatment. What we do recommend for you is to isolate yourself at home and monitor to make sure the symptoms do not get any worse. Going now to severe pneumonia. So this occurs in about 14% of the cases. And the presentation for severe pneumonia is based on difficulty breathing. So that's what we call respiratory distress. That means if you're breathing really hard, that means more than or greater to 30 breaths per minute, or you have low oxygen level in your blood. So in those cases, what we do is we assess the patient and we admit them to the hospital for monitoring to make sure it does not get any worse. And for the low oxygen in the blood, if they do have it, we'll give them supplemental oxygen, usually through the nose, to make sure that their oxygen level in the blood remains normal. And as we know that if it's confirmed to be COVID pneumonia, we know this is a viral infection, therefore there's no role for any antibiotics. And lastly, the most severe cases will be called critically ill COVID-19 infections. So that's very rare. It occurs about in 5% of the cases. And almost all of the mortality, people who die from it, will be within this category. So of all the COVID-19 infections, our best estimate for mortality, people who die, it's estimated to be around 2%. The clinical presentation for the people who are critically ill is usually to have respiratory failure. That means that your lungs cannot breathe for you, and that means you need a breathing tube to be on a breathing machine and life support. The main reason that we intubate people is due to a complication from the COVID infection called ARDS. ARDS stands for acute respiratory distress syndrome, which just means a severe inflammation immune response within the lungs that causes lots of fluid within the lungs, such that your lungs cannot breathe for you. If this immune response and inflammation goes outside of the lungs to the rest of the body, then there's a complication what we call septic shock. In those cases, what you have is very low blood pressure. And when you have very low blood pressure, you have low levels of blood and oxygen supplying to the rest of your organs. And that's when you go into multi-organ failure, which is a cause for death. One of the most common organs to be affected is your kidneys. So you go into kidney failure or renal failure. For those critically ill cases, what we do is we monitor and care for them in the intensive care unit in the hospital. And we try to optimize what we can by supportive care. By supportive care, I mean we try to optimize their mechanical ventilation. That means a breathing tube and a breathing machine. As well, if their blood pressure is very low, such as in septic shock, we give them lots of IV fluids and also special medications called vasopressors to increase their blood pressure to the normal range. And if they have organ failures, we try to temporize and try to replace those organ functions. For example, if you go into renal failure, what we do is we put you on temporary dialysis. So in those cases, when you have severe patients who's in the ICU, there are risks for other infections as well. So if it is suspected that they have a bacterial infection, such as a superimposed bacterial pneumonia, then we add antibiotics. And currently, based on the recommendations, there's no role for steroids. That's all I had in terms of the management and the supportive care. So now I'm going to move on to the specific COVID-19 therapies that's currently being studied. So there's a lot of options, and currently in the world, there's about 300 clinical trials going on right now. The two most famous one and well-known one is the one I'm going to talk about next. So the first one is called hydroxychloroquine or chloroquine, and the second one is called remdesivir. So before I go into detail about any of those two treatments, I just want to give the bottom line right now, and that is there's not enough evidence from clinical studies to support the use of any of those above therapies for COVID-19 in the clinical practice. So we do not use it outside of clinical studies and clinical trials. So this is just a diagram to show how the virus infects the cells in the body to cause the infection. So if you can follow my mouse here, so this is the virus. The virus is called SARS-CoV-2. It binds and enters a cell, such as cells in your lungs, to cause infection. Once it enters the cell, it's going to try to replicate its genetic material and other components too to make progenies. And these sort of daughter virus particles will then exit the cell to infect other cells, which causes and propagates the infection. Outlined here are different targets that's currently being studied, specifically to treat this viral infection by inhibiting the different steps that the virus uses to cause infection. So for example, over here, you have hydroxychloroquine or chloroquine. It's usually used as an anti-malarial medication. However, in studies on cells, it's known to inhibit the entry of the virus into the human cell. And then over here, you have the remdesivir, which is a broad spectrum antiviral agent. And its main role is that once the virus enters the cell, it'll stop the replication of the virus. So I want to go into details about the study so far done on these two agents. So the first one will be about hydroxychloroquine. So the most famous study that's been sort of in the newspapers and the media is this study published in the International Journal of Antimicrobial Agents. It's a non-randomized open label study that's done from Marseille, France. What they did is they included patients with COVID-19 infection, and they treated them with hydroxychloroquine. And they compared it to people who either refused to be treated with hydroxychloroquine or people from another center that does not have the privilege or access to be treated with hydroxychloroquine. In terms of the outcome, they looked at how the patients can clear their virus by the nose swab repeated at day 6. So these are the study results. I just want to emphasize this is a very small study where you have 20 patients that's treated with hydroxychloroquine and 16 patients in the control group. What I want to emphasize is that the majority of the patients is either asymptomatic or they have mild symptoms. So URTI just means that it's symptoms or infection of the nose and throat and didn't really infect the lungs. As you can see, only about 30% in the hydroxychloroquine group really had a pneumonia. So in these asymptomatic and mild symptom cases, we do not recommend treatment at all. What the study found is that about 70% of the patients who were treated with hydroxychloroquine had cleared their virus based on the repeat nose swab on day 6. And this was found to be significant. So what the authors concluded is that hydroxychloroquine has significantly decreased the viral load and helped clear the virus. However, in my opinion, I think this is a poorly done study and it's flawed in many settings. So the first one is the methodology. So what we usually say is to test a drug, you need the gold standard study design, which is a randomized controlled trial, where you randomize patients to either the drug or a placebo. However, this study did not do that. And the randomized controlled trial is the gold standard because it makes sure that each treatment arm it's balanced in terms of their characteristics. Secondly, in terms of the patients, they had a very small sample size. That means about 30 patients in each group. Truthfully, for studies for testing drugs, we usually need hundreds of patients. And most of these patients have mild disease that doesn't require any treatment anyways in clinical practice. And what I found suspicious is that 6 patients within the study was excluded from the analysis because they got worse in the ICU where they were transferred to the intensive care unit or they died. And those 6 patients, most of them were in the hydroxychloroquine group. In terms of the outcome, I do not think they looked at the right outcome because the outcome we really want to know is the outcome that's clinically important. That means it matters to me, the doctor, and also to you, the patient. That means whether you feel better, whether you get discharged from the hospital, or whether you live or not. And the study did not look at any of those outcomes. Because of these flaws, in fact, what happens is the editor-in-chief of that journal agreed that it did not meet the publishing standards. So this supports that this is a flawed study, and there's not enough evidence right now for hydroxychloroquine. So next, I'll be moving on to remdesivir. So the most recent study on remdesivir, to my knowledge, is the one that was published in 2020 on April the 10th, so just 10 days ago, in the most prestigious journal called the New England Journal of Medicine. What they did is they did a case series study across the world where they included countries including Canada, US, Europe, and Japan. They included all hospitalized patients with severe pneumonia who were able to get the drug, and they treated these patients with the antiviral drug remdesivir for 10 days. And those are given IV, intravenous. Unfortunately, they did not have a comparison group. And for these patients that were treated, they followed these patients for a maximum of 28 days in terms of various clinical outcomes, whether it's how much oxygen they need, whether they clinically improved based on a sliding scale, as marked by the physician, or whether they got discharged from the hospital, or whether they died. So again, this is a very small study where they included only 53 patients that was treated with remdesivir. And again, there's no comparison group. The difference between this study and the last study is that this study had included severe pneumonia for which we needed treatment for. As you can see, the majority of these patients required either invasive ventilation or ECMO, which is just a form of life support. They did found significant improvement though, in terms of 68% of patients who were treated with remdesivir had a decrease in the need for oxygen. And they found that most of the patients, about 84%, had significant clinical improvement. In fact, that about 57 to 75% of the patients who required life support were able to come off life support. Again, about 47% of the patients were discharged from the hospital and 13% of patients died. Again, I would say that this is not a very well or of good quality for a study on new medications for COVID. My main critiques are the following. So first, on the methodology, again, this is not a randomized controlled trial and there's no comparison group. I think this is important because we don't know the outcomes for people who are just treated with supportive care without remdesivir. As far as we know, those patients may have just as good of an outcome compared to patients who are treated with remdesivir plus supportive care. Again, in terms of the patient, it's a very small number of studies, and it's been selected and handpicked by the physicians and the pharmaceutical industries. So that introduces lots of bias because I think the physicians ourselves will pick patients that we think are most likely to succeed and live. And then thirdly, in terms of the loss of follow-up, for remdesivir, they only follow up for patient about average of about only 2 weeks. And I don't think that's enough, especially for these critically ill patients. It takes a lot of time to just get better. So I just want to highlight that the main reason we're hesitant as doctors to start using them in the hospital setting outside of clinical studies is that these agents, just like any other medications, have lots of side effects. So for example, I just listed a couple, and that's not exhaustive for the side effects for hydroxychloroquine and remdesivir. So the common side effects for hydroxychloroquine or chloroquine is GI upset. So that means nausea, vomiting, abdominal pain, diarrhea. The main thing we're worried about is something called QTC prolongation. It's just hydroxychloroquine has a risk of causing heart rhythm problems, and that could be potentially fatal. For remdesivir, it has major side effects from the studies to cause severe and serious injuries to both the liver or the kidney. Now, of course, these risks and side effects does not happen to every patient, but there's still a significant risk. And our first principle is do no harm at first. So I think I'm just going to end there, but here are my take-home messages. Is one, the clinical diagnosis is based on symptoms, plus usually a nasopharyngeal swab. For the treatment, most cases, and I stress this, most cases are mild, and the infection will resolve by itself, and usually can be managed at home. And for the severe cases that's admitted to the hospital, we mainly do supportive care. Now, there are many potential experiments that's currently undergoing experiments right now, but I think more methodologically sound clinical trials are required before using them in a clinical practice. So I think that's all I had for the presentation.
All right, thank you, Dr. Bai. Thank you for your time. And I think what you said about the clinical diagnosis, I mean, your entire presentation was very informative. You had clinical diagnosis, you talked about test accuracy, how it's interesting how there are false positives. You talked about the management, where there's a spectrum of diseases. There's mild, severe, and critically ill. You talked about the therapy, where there was hydrochloroquine and remdesivir, and how both of these have side effects to them, so that's why they're not used right now. Right now, unfortunately, I don't think we have time for questions, but at the end, there will be time for questions if you guys have any. I would like to pass the time to my fellow host, Ms. Han now.
Hello, hi. Thank you so much, Eric, and thanks so much for the counselor Carol and Dr. Bai's sharing. And as you said, that I already seen a lot of the good questions, great questions raised by our audience, but we will leave it to the Q&A session. And next, I would like to welcome Professor Wang to give us some basic common knowledge about the epidemiology concept to help us better understanding the COVID-19。这里边也特别要介绍一下我们的王培忠教授，他是我们纽芬兰纪念大学的教授，同时呢，我们也是我们北美华人健康协会的主席。那么下面呢，就有请我们的王教授给我们来一个科普的小讲堂，让我们更好的了解一下我们这个 COVID-19。Okay, now time is yours. Professor Wang?
Eh, 王教授，你的声音还没出来。
Okay, while we are waiting, and we welcome any questions to the chat box, and we will collect it and we'll leave it to our Q&A session. So if you have any questions, don't feel free to leave it there.
OK， 现在应该可以了。
现在可以。
自己跟自己说了半天，没有关系，就是现在从英文转到中文里边来了。我呢报告很短，我呢不是报告形式，就是说一些相关的东西，主要是给后边2位主讲人多留点时间，因为后边2个主题非常重要。一个呢是这个检测的技术，存在什么问题，大家应不应该去检测。第二个呢是对检测的指导，什么人该接受检测，什么人不该接受检测，到哪检测。所以呢，我呢就是讲的很短，我呢这里提供一些信息，这是北美华人健康。如果呢我会把这个信息呢发在上边，另外呢可以其他的消息呢我们也可以发一些。这个我就简单的说，现在安大略的这个现在的状况，加拿大整个的状况，这是今天的这个结果是，我特意拿这个绿颜色，这叫绿颜色标出了安省的这个情况。安省跟纽约市呢差一些，我们现在也有多伦多吧，大多伦多也大概600万人，大纽约呢800万人，这是纽约在最 top 的。我们这里呢是就是发病数这个表做的非常有意思呢。这个图它把大家放在一个共同的起点上。就是都从100个病人开始，从那往上升，看升的速度，所以就可比性比较好。所以来讲呢，加拿大的情况，多伦多的情况都到了一个高点的平台期，所以下一步呢，应该我们就不知道下降的速度有多快。但如果现在措施继续的话呢，肯定是在下降，但是呢，这个整个的时间会拖得相对长一长。至于呢，我今天刚那个接受采访，我说，至于什么时候学校 open， 什么时候那些复工，是一个有计划的，一步一步的来。这个另外呢，也不完全是一个完全的公共卫生问题，还有好多平衡的问题，怎么来做好这些平衡，这是我要说的。为了把我的报告简短一些呢，我就呢给大家呢分享呢我这几天 reading， 我的 reading 还比较多的，就是文献看的比较多。跟大家分享，第一个呢，大家都对潜伏期非常关注，潜伏期大家也都明白什么意思，我就不在这里讲了。但是现在呢，中国呢刚出了一个研究，我们一般的假设呢，潜伏期呢就是最长12天，一般的 medium 中间值呢是5天左右。但是他这个研究很有趣，是中国武汉的做的研究。他呢从这个暴露非常清楚，去过武汉回来了，所以他的时间好计算，从暴露时间点计算出来。他就说年轻人的潜伏期要明显比老年的潜伏期要短，年轻潜伏期呢是7天，老人潜伏期呢从10天到11天，这个信息非常重要。所以来讲呢，我们是隔离14周，可能对一些年轻人可能是应该是够了。但是对一些老年人来呢，隔离可能是不够的，所以这个信息呢，就让大家及时的反馈一下。这个潜伏期呢，并不是每个人都一样的，分人群组是不一样的。另外呢，这个大家可能最近也看到了，我们中国呢就是打这个卡介苗打的比较多，现在呢对这个非常关注。前不久呢有一篇报道，他比较了一下，打卡介苗的国家，它的发病人数相对要少，不打比卡介苗的这个国家要低。但是这个我们叫流行病学来讲呢，就是这个生态学分析。生态学分析就是大的这个相关分析，所以它不能直接说因果关系。最近呢又刚出了一篇文章，重新检查这个事情，所以他觉得这个还是有一定道理的。 虽然这篇文章不能证实卡介苗有保护性，但是呢，这个非常值得研究的一个问题。我知道欧洲在德国、在瑞典是瑞士已经开始做临床实验，就给人打卡介苗是不是提供了一些保护作用。这也呢，希望大家跟大家通报一个最新的结果，就是这几天刚出来的，这个是18号登出来的。这个也是呢，在这个口罩的问题争了很长时间了。实际来讲呢，你要关注北美华人健康，我也写了若干篇文章，就不在这里再发挥了。口罩来讲呢，实际上世界卫生组织，包括美国 CDC， 包括加拿大公共卫生官员说，这个有病戴口罩，没有病不戴口罩。实际这个评论本身就是没有科学根据的。这个 recommendation 当时主要的目的实际是为节省口罩，因为口罩的这个用量太少。另外一个呢，人群当中的患病者比较低，所以你不戴口罩呢，感染风险比较小。但是现在状况不一样了，已经大流行起来了，所以呢，建议戴口罩。所以呢，但是始终没有比较好的 evidence。有一些，但是最近的这篇文章就是4月10号发表这篇文章的，非常分析了到现在为止所有的研究，总结一下，所以它结论非常清楚。戴口罩是有保护性的，有帮助的，所以大家呢这个呼吁，我会在说这呼吁。我本来想分享我们呢正在调查的一个科研结果，这项课题呢是联邦政府有主讲课题，是我主持的。另外呢有多伦多大学的2个教授，有 Ryerson 大学2个教授。这个调查呢已经开始了，我们目前收集了800人左右问卷，结果呢已经初步结果出来了，最后结果呢还要等一段时间。因为时间不够嘛，我就去分享几条最重要的信息。比如说这个知识缺乏，报告知识缺乏的比例比较高的，只有13%的人认为知识就是我觉得不缺乏了，我足够了。我就说明什么问题呢？尽管信息网络这么发达，大家看到信息特别多，但是大家还感到对预防的治疗就缺乏40%，对治疗的缺乏60%等等等等。这样来讲，这个信息。另外呢，对这个观点总体来讲还是比较乐观，91%的认为疫苗呢可能能够将来能够控制这个疾病，这是比较好的。但是疫苗是不是真能及时出来，是不是真能控制疾病，并不好说。一般的疫苗呢需要几年，过去呢最短要18个月，但是现在呢国际合作非常密切，大家呢都在拼命的做这些东西。有可能会提前，但是也不可能太早。但是呢，另外一个问题呢，现在科学界又在讨论，如果疫苗出来以后，是不是提供保护力，也并不一定的并不确认。那还有一个原因呢，这个病毒在不断的突变。我们疫苗出来之后，当时的病毒突变到什么程度也不太清楚。总体来讲呢，疫苗是一个比较好的 solution， 但是呢，效果有待验证。另外呢，大家知道阴谋论是比较多的病毒源头在说，也多数人认为呢并不乐观，病毒会与人类的长期相伴。实际上也反映现在目前的一个共识。再有病毒这个来源的问题，我们做了一个单选野生动物来源的实验室意外的，在中国人群中，这个人 sample size 也不小了，而且教育文化程度都是很高的了，有38%的人认为实验室意外。现在这个调查还在进行，我不知道全部结果上来以后是不是还保持这个数。这说明什么问题呢？我们说明了现在的宣教非常重要。从现在的证据来讲，这个病毒来源只能是野生动物，除非呢有特别这个强的证据来否决。所以这个实验室意外的这个阴谋论，这个很长时间了，这个影响呢很难消除。再有呢，说生物武器的人的6%，实际上是根本就不可能的。另外，我最后一个问题呢，就是这个报告的最后一个问题，就是认为自己的感染的可能性有多大？超过1半的人说自己有可能会感染，这个挺可怕的。所以这个大家都在恐惧，都在担心，这就直接呢影响到我们这个其他的事情。至于影响来讲呢，别的我就不说了，就说经济影响，64%的人感到这是大流行对自己的经济产生影响，这可以理解。我们中国人、华人从事服务业行业的比较多，可想而知影响有多大。13%的人报告的，因为这次这个大流行失掉了工作，这个并不。至于这个呢，我就更快的说一些了。至于我们简单的评估了一下 心理学这方面的恐惧75%，感到非常紧张的是77%，感到困惑的是68%，更 disturbing 的一个呢，10%的人报告呢自己亲身经历了这个因为这次流感那个大流行吧，受到了歧视，这是非常非常糟糕一个事儿。我想呢，我就不再多讲了，把时间呢留给后边。最后呢，谢谢大家。
Thank you so much, Professor Wang's great sharing, and I think that is why we definitely need today's event. 谢谢我们王教授的这个分享，虽然简短，但是却一针见血，很多重点。干货满满的知识点给我们画出来了，我相信这也是我的一个科普小讲堂，感觉到收获非常大。正是像您做的这个调查研究的这个结果给我们展示的，就是确实我们在这场疫情过程当中遇到了很多迷茫、很多紧张、很多的困惑，但是因为我们今天这场活动呢，请来的是我们真正领域上的专家，在一线实践的医务人员，他们用他们自己的研究水平、专业水平和专业的知识，让我们可以用我们的科学去守护我们的健康。所以非常感谢您，也非常感谢我们所有的分享的嘉宾。So next, we would like to invite Ms. Xie, and she is an expert who works in the epidemiologist of the Durham Region Health Department. She would like to share with us the Ontario COVID-19 testing guidance, case management, and contact tracing. So I am sure a lot of our audience are really expecting your sharing, especially in the current situation. So now the time is yours, Ms. Xie. Are you there?
我在，你听得见哈？
Thank you.
大家好啊，我先介绍我本身呢是做流行病的，我在当地的公共卫生部门，所以我会重点讲一下这个 public health 在这次的 pandemic 扮演的什么角色，然后一些那个安省的关于的检测，所以就是现在的检测的那个 guideline， 还有谁是优先被检测的人群，如何得到实验室的检测，而且在哪里检测，然后呢怎么查你的检测结果，还有另外一部分是关于 case management 和 contact tracing 的，我最后会讲。首先我们来看一下这个检测的那个，就是每1000的人群里头检测的人口，这个是13个省和地区的比较，你们可以看到这个安省哈，它其实是比较落后的，前段时间已是被新闻媒体批评的，你看在整个13个地区，安省是倒数第2，每1000个人群当中呢，只有9个人就有检测，然后到 North West Territory 的话是32，所以安省的检测其实它 capacity 呢还是比较低的，跟其他省比较起来，虽然它在4月差不多8号左右的时候，它就是发布了一个政策要增加那个检测量，待会儿我会讲到。然后下一个呢，这个你可以在这个安省的那个 Ministry of Health 那个网站上可以查到它最新的 guideline， 这个地方，这个是4月8号的，然后其实更新的还有一个是最新的是4月15号，它有个那个 Provincial Testing Guidance document， 你可以查到就是哪些人群它是优先检测的人群，我会着重讲一下。就是分2类哈，就是根据4月15号最新的那个 guideline 的话，如果你有症状，这里所说的症状呢，最开始它只是有呼吸，还有呼吸困难、发热和咳嗽，后来它加上了其他的症状，比如说咽喉疼痛然后鼻塞，其他的呼吸道，然后还加上了失去味觉和嗅觉以及消化道的症状。就是如果你有这些症状的情况下，并且你符合以下的人群包括比如说你是在比较聚集的地方，像无家可归的避难所或者一些精神中心，还有监狱集体住宿和老年院和护理院这些地方，或者呢你是医护工作者或者是提供护理的人，这里的 first responder 包括警察呀急救员， 还有呢，如果你是一些特殊的病人，比如说你经常要去医院进行治疗的癌症病人，或者是做透析的，器官移植的，还有那个怀孕的妇女，还有一些 essential worker， 比如说是要跨境的人员，这些人，如果他们有症状，他们这些人以及他们的跟他一起居住的家人，他们是属于优先检测的人群。还有一部分呢，是你有症状，但是并且你有符合以下的一些危险因素，比如说你是跟这个确诊的病人有密切接触的，你有 travel history， 就是你有这个旅游史，或者你是65岁以上，并且有其他慢性疾病的这些人，就是你属于以下一类人的话，你是优先检测的人群。然后还有一类人呢，是属于无症状感染的，就是其实现在安省它是不推荐对没有症状的人进行检测，但是有一些例外，比如说你从医院老年人，你从医院转到老年，你没有症状，这部分人呢，他会对你进行检测。还有一部分人呢是你没有症状的，但是呢你住在老年院或者是护理中心，你的室友他是有症状的确诊患者，他也会对你进行检测。还有就是妈妈有感染了新冠病毒的所有的新生儿，在出生24小时之内也会进行检测。他这个政策呢应该是4月15号左右开始更新的，因为在公共卫生部门，它其中一个职能是，当在一个它叫 institution， 当在一个比如说医院呢、老年院、护理院，它出现了一个病例，就是新冠病毒确诊病人之后，这里的它叫一般是环境卫生监督员叫做 public health inspector， 他们就会到这个地方进行传染病的调查。在进行调查当中呢，他们就会把那些人进行检测。然后我注意到，因为我是在后台就是管理这些数据我注意到从4月10几号开始，有很多老年人他们是无症状感染的，他们是没有症状的，但是呢他们的检测是阳性，但在以前是没有遇到的，就是在4月10几号之前我们从来没有发现这种情况。因为当时安省的政策是只有你有症状的时候，然后你还符合其他的几个条件，他才会给你检测。所以我最近发现就是有好多，至少我碰到10几20例，就是在老年院的老年人，他们在检测的时候是阳性，但是还没有症状。所以这个也是一个方面反映了他那个政策的改变。但是呢，可能就是这些无症状的人呢，我们到现在还不知道他到底是处于潜伏期的无症状感染呢，还是因为他潜伏期已经过了，他长期携带。因为我们那些病例追踪也是在上个星期才陆续有这些无症状感染的，公共卫生部门会陆续对他们追踪，看一下后续他们会不会有症状出现。这个是优先检测的人群，就是你符合这些呢，你是可以得到优先检测。那你可能会问我怎么能够得到检测呢？这有首先呢，在安省它有一个网站，我觉得当时那个议员他也提到过，你可以去安省这个网站上，有一个 online self assessment， 你去他会问你一些问题，他会问你有什么症状，如果你有，他会问你是不是属于这个以下几类人群，然后根据你的结果呢，他会跟你说指导你是否需要检测。这个 online assessment 是一个方式。如果呢你怀疑，比如说你有症状的，或者怀疑你有阳性的新冠病毒有接触的情况下呢，有几个方式他们可以 refer， 就是把你 refer 到那些检测中心。第一个呢，就是打电话到你的当地的公共卫生部门，我会讲一下到底怎么联系他们。就是在安省呢，一共是34个公共卫生部门，然后这个 website 上你可以查到所有的公共卫生他们的联系电话和联系方式，这是一个办法。还有一个
小的内陆，
还有一个办法呢， 你可以打电话到远程叫做 telehealth， 就是远程那个理疗中心，但他们现在电话非常忙，有时候会等几个小时。所以呢，其实如果您给我找到当地卫生部门是比较好的，可能比较容易接通一点。你也可以打电话到你自己的家庭医生，就是这几个地方他们都可以 refer 你到那个叫做 COVID-19 的 assessment center。最后一个方式呢，你是可以直接联系这个 COVID-19 assessment center。有2种方式，有些那个就是 COVID-19 的叫做评测中心，他们会有电话。有些呢，它是只是提供一个网上的 online form， 就是你需要提供很详细的你的医疗证啊、你的住址啊什么的填进去，他会说你需不需要检查你的症状啊那些东西。然后绝大部分这些检测中心呢，它是需要首先要那个 book appointment 是要预约的。所以呢，我提到，当你经过这几种方式，打电话到你的公共卫生部门，或者是打那个远程医疗安诊，或是你的那个 family doctor， 当你打电话给他们之后呢，下一步呢，他们就会问你一些很多筛查的问题。如果他们觉得你们符合这个优先检测人群，那个几个 category 的话，他们就会 refer 你去我提到的那个评测中心。还会对你进行进一步评估，他觉得你是可以了，然后他才给你检测。所以下面我来讲一下那个how to go to next， 我来讲一下这个 assessment center。现在到目前为止安省大概是有100个左右的 assessment center。我在安省的卫生局的网站上没有查到一个全部的 list， 但是呢，如果你去当地的自己的公共卫生所属的公共卫生部门下面，一般他们都会有，就是在他们区的那个评测中心有哪些大部分这些就是 COVID-19 的那个评测中心呢，他们是在医院外，就是它不在医院，可能是在医院外面有一个什么棚啊，或者有些是在那个社区中心设立的，这样呢，它就避免就是有可能感染的人直接去急诊部门，或者直接去那个你的家庭医生那里。还有一些它叫 drive through， 就是有点像你去 Tim Hortons 买这个吃的时候是吧？你开车过去，你点餐，然后你就拿着吃的走了。它这个 drive through 呢是有点像类似的概念，就是它设了一个点，比如说在哈姆顿它是一个山上，它设了一个点，你开车过去的时候，但你也要大部分时候你要预约好，然后你开车到那个地方，你在车里面呢会远程和他那个医生会问你有关情况，比如说你的症状啊，你有没有 travel 史啊，你有没有接触的病人啊。如果他觉得你符合了，然后他就有人来给你取那个样。刚才那个医生讲到了，就取那个棉球，取那个咽拭子。他就是这样子，就是你就不用下车，只是在车上就完成了这整个的过程。然后呢，我说过了，刚才讲过，其实你打电话到你的公共卫生部门，或者是你的医生也好，或是那个远程医疗那个电话热线也好，他们把你 refer 到这个 assessment center 去之后呢，你到那个他还会进一步的给你再评估一下你是不是符合他们的那个优先检测的标准。就是一个大的方向呢，就是刚才我看到那个安省的那个，它有一个 guidance， 但是每个评测中它可能有一点点的不同。就是我最近看一个新闻，就是大部分就是即使你不是 refer 去那个检测中心，可能有20%或者30%，他觉得你不符合检测的标准，然后把你送回来了。然后绝大部分这些地方呢都是要预约的，你不能够说我自己去看就行了，而且需要 refer 的。然后下一个呢，我是想讲一下当你检测之后呢，你怎么知道实验室的结果？在开始的时候，我们在3月份的时候，我开始输数据，我发现有些检测结果好像要1周、2周以后才拿到。比如说3月18号测的，可能到4月初了才拿到结果。但是现在非常快了，现在就是绝大部分的病例我就是经手的，一般是在1天、2天之内，或者3天之内。最多都已经出结果了。它是这样子，就是在 实验室的结果一般是这样，实验室它有阳性结果之后呢，它一般会发给当地的公共卫生部门，让公共卫生部门呢会跟你联系然后呢你会得到结果。一般比如说我4月18号检测的，一般实验室它可能18号当天或者19号它就出结果了。19号出结果之后呢，它会马上传给公共卫生部门。那个时候呢，当公共卫生可能19号或者20号就会跟你联系。这是一个方式，还有一个呢，最近安省它有一个新的 online portal， 你可以到那个地方去看。你到那个 portal 上去看之后呢，你可以把你的医疗卡信息输进去之后，你可以自己检测你的结果。但是有些公共卫生中心它还是有规定，如果你是阳性的病例的话，你还是要通过它得到你的检测结果。所以这个比较方便了，因为你在家里只要上网把你的信息输进去，你就可以看得到你的检测结果了。最后我想说一下的是那个疾病的管理和那个叫 contact tracing 就是密切接触者的追踪。我想简单介绍这个叫做 public health units 在安省。可能我觉得在这个COVID-19 之前，可能好多人都不知道公共卫生是干什么的，然后自己的公共卫生部门在哪个地方。然后呢这是一个安省的那个图，安省现在一共是34个公共卫生部门。然后你看这个比较大的在 Northwest 和 Northeast， 因为他们的人口很少，然后主要是集中在安省的南部。然后呢，有5个我们所说的 GTA， 就大豆地区呢，它是5个公共卫生部门，一个是多伦多，还有一个是杜兰区叫 Durham Region， 我是属于杜兰区的。然后呢，在西边有Peel Region，Peel 就是在密沙沙加那个地方，在北面有再往西有 Houghton，再往北呢是 York Region， 比如说你说的 Richmond Hill 或者是 Markham， 它是在 York Region。整个安省有1000万多的人口，有一半的人口以上都是集中在这5个区的，这个5个区就叫做 GTA 大多地区。然后主要的病例呢也是集中在这5个区的，所以呢34个公共卫生中心，你可以查一下你属于哪个区，然后有个联系电话。这个是大概就是公共卫生的那个介绍。我想再讲一下在这次疫情当中，公共卫生到底扮演什么角色呢？你们可能就是媒体上听说这个，就是前线的医护人员他们是直接面对这个病人的，他们的主要职能是治疗。在公共卫生呢，它其实是一个预防的职能为主。如果你看一条河的上流和下流，那个河的上流你可以看成是预防，那个到了下流之后呢，它就是一个治疗为主了。所以如果上流那个没有搞好预防的话，那个下流的病人就增多了。所以我们的是属于上流的责任，是属于预防的责任。具体在这次那个新冠病毒爆发当中的公共卫生很大一部分他们做的工作是叫做 contact tracing。我就简单那个图分析一下什么叫 contact tracing。你们最近可能也看到那个联邦政府他在招那个 volunteer 做 contact tracing 和 case management， 因为这个非常非常的费时和费人力。比如说我是一个病人，这里我生病了，然后呢任何一个病例他都会当地的公共卫生部门他都会收到，因为当医院或者医生实验室检测到阳性，因为现在新冠病毒是法定的传染病，他检测到这个病之后，他会报告给公共卫生部门所属区的。比如说我本身是杜兰区我住在 A， 然后他会报给我，这个病人是有新冠病毒了，我们就收到这个病例。收到之后呢，这个在公共卫生呢，公共卫生会打电话去确认这个病人的联系方式，还有他的情况，说就是你的那个这个叫做流行病调查，就问他那个疾病什么时候发病的，发病时间，然后你在发病，现在是主要的指的是在发病前的2天之内，你有没有接触过其他人？比如说这个病是我接触过他，我去过这个 Superstore， 我去过这个 Walmart， 我也去过这个银行，我去过哪个地方然后呢，然后公共卫生部会根据他这个提供的消息呢，又找到他的那个密切的接触者，然后根据这个密切接触者呢， 它会又对它进行监测。如果这个密切接触者在一定时间之内又转成了新冠病毒呢确诊病人，然后他又会进一步的像那个 find out 一样进一步进行追踪，说你接触过追踪什么人，所以他这个其实你看是个像那个 spider 一样 spider web 一样的，就有点像那个 detective， 就是检查追踪的，所以他其实每一个确诊的病人的后头可能有几十个甚至上百个的密切接触者，这些呢都需要公共卫生的护士他们大量的去就是每天打电话询问调查，而且每一个不管是他的确诊病人或是密切的居住者，他都有一个档案。然后像确诊的病人和他们是每天至少要打电话一次，然后要记录他的体温，你的症状是什么你去过哪个地方，今天是不是待在家里的？因为他要 make sure 你是对轻症病人你是在家的 self isolation。然后呢？如果有症状加重，公共卫生他会跟他联系医院或者是急救人员，所以他每天就是每个病人每天他都会打电话去询问，然后有详细的记录，这个就叫做 contact tracing， 所以这个是传染病中比较常用的一个办法，就是希望通过这个 contact tracing 把所有的确诊病人和他的密切接触者都找出来，然后把他们在家里不要出来，或者是在一个地方隔离，通过这个手段呢，就达到切断传染病传播途径的作用。这个是个 contact tracing。还有一个呢，概念叫做 case management。这个 case management 呢，跟这个医院的 treatment 是不一样的，不是治疗。公共卫生呢，他们不会治疗病人，但是他们是叫做管理。就是我刚开始提到的，如果你生病了，是一个确诊病人，轻症的一般也会在家里隔离。在家里隔离的时候呢，每天呢有那个护士，他就会打电话，公共卫生护士打电话问你的情况、疾病的情况。然后一旦有疾病如果有恶化了，他会把你 refer 到医院，或者是给你叫急救车。然后他也会做 documentation 很详细的你的那个每天，我看那个记录哈，比如说今天就是比如说接触过哪些人，然后呢去过哪个地方，他都会有记录的。主要的目的是保证这些新冠病毒的患者能够他的病情能够每天得到监测，如果有需要能够得到治疗，而且来保证他们是在家里隔离，这也是一个公共卫生他们所做的工作。我想好像我的那个就到这里了，哈哈，看看。
谢谢我们的谢女士的给我们的分享，真的是深入浅出的普及了这个公共卫生部门在这个 crisis 当中起到的作用。以前我们可能还真的很不了解，但是我觉得您的科普让我们觉得非常的清晰，而且同时呢，对于检测的流程和它的结果也让我们有很清晰的这个了解。我也看到群里面有很多朋友可能也有一些问题，我们留到最后，然后再一起讨论。OK。So the last but not least, let's welcome Dr. Yang Yu. She is a medical microbiologist at Eastern Health, the Newfoundland and Labrador Public Health Microbiology Laboratory. And she also is a clinical assistant professor at Laboratory Medicine, Faculty of Medicine in Memorial University. So she will introduce the laboratory diagnosis of the COVID-19. 那么接下来呢，我们要重磅邀请的就是来自我们纽芬兰纪念大学的于教授，他呢是一位医学微生物专家，所以他接下来要跟我们分享的就是有关于实验室诊断的相关情况。有请我们的于教授。
Hello. Let me share my
screen.
Yeah.
你 share 你的 screen 就可以。
Did I share it already?
Okay, I haven't seen it yet.
Okay, let's see.
Not yet.
Where's my screen? Sure.
在我们的这个于教授找这个 PPT 的时候，我也刚刚真的上了一下我们这个 Canada Government 的这个网站 Canada.ca， 上面有我们的这个关于 volunteer 的 recruitment 的 campaign， 是截止在4月24日就截止了。其实每一个人都可以为我们的 community give back 做一些实践，即便是我们在家，而且它对于的专业要求并不是我们说一定要有医务背景的，其实大家很多人都可以 contribute。所以如果感兴趣的，也希望大家可以去填一下这个 volunteer recruitment campaign 的这个应招 apply online 就可以了。
Yeah.
You got it.
Yeah, now it's coming.
Okay. All right. So, hello everyone. It's really an honor to be here to share with you about some of my experience working in the lab for testing. So I'm going to talk about laboratory testing for COVID-19. Actually, would be more specific is for microbiology testing. We know that since December 2019, there's so many change and knowledge obtained about this infection. There's so many name change, including how the disease will be called and the virus causing this infection. So now we all know that it's called COVID-19, that's the disease itself. And the virus causing this infection is called official name, SARS-CoV-2. And the name given because it shares a lot of genome similarity with SARS that caused the outbreak in 2002. Like if for those interested in learning about this virus, like 2019-nCoV was another name. If you do literary like search, remember to include that. So why microbiology testing is that important? The COVID-19 clinically is not specific. So that means you cannot tell from the symptoms or signs that this is a COVID-19. It has a lot of overlaps with other seasonal respiratory virus infection, including influenza. So it is very important to have a specific testing for the virus itself. It has some meaning in both individual level for the patient to be able to diagnose an infection and proper clinical management or infection control property could be applied to prevent any further transmission. At population or community level, it's very important to know the level of prevalence of the infection so that proper measurement policy could be also established. A lot of questions already. I see that people ask why, like we test that many, we test like in certain province, certain area, we test more, certain areas we don't. So the microbiology lab actually depends on the pandemic or the outbreak phases. There are different strategies. In the ideal world, if we don't have any limit, we can test everyone. But we have limit resources and we have to be smart. So during the early phase, it's called containment phase. It's basically we can test more. So we have more supplies, we can test more. So that's the time we probably also have less patients. That's why at the very early stage of the outbreak, we have a case definition. We say, oh, this is a patient with certain symptoms or signs and has a certain contact. But with more and more cases found out, especially there is a community transmission, you cannot test everyone. Then you have to be focused. So that's the time you have to decide you test more patients that's severe that they need to be hospitalized. And for certain patients that they are more vulnerable to have a bad consequence when they got infected. For example, those immunocompromised because of like cancer, chemotherapy, or some patient, they have family member in their family has that condition, or seniors in long-term care. In certain professions, like for example, the healthcare workers, you want to know they are not infected so that they can take care of the patient without giving the infection. So this is the reason why we test, and at a certain time we test more, a certain time we have to say, sorry, we cannot test you. So we all know that the COVID-19 is caused by this RNA virus. So this is a structure, so is RNA inside the cells, and with some structures, so all of them has some role to play, for example, to invade the human body and give infection, and some might be causing more production of but luckily also this different structure gave us a tool to test virus. So these are the various image that everyone familiar, but what really the virus look like, it's not that pretty. So these are the electron microscopic picture. So really proud that China CDC, they are the first one culture and isolate this virus from clinical specimen. And that's a picture they took January the 6th and published. So later on, more and more pictures and isolation. This is a picture also from China CDC from environmental samples. So how can we test this virus infection? Can we like look under the microscope? Can we culture? Unfortunately, that answer would be no. So first of all, to culture is really complicated, takes a long time, and more importantly, is of significant biosafety concern, because this is a virus causing really bad infection. We don't want to jeopardize the laboratory staff by doing that. So then the test right now used in clinical management, in community management, also folks know about the molecular testing. That is real-time PCR, and this is more or less considered a gold standard. And also more and more on the horizon, we know that people ask about antibody testing or the serology testing. But the question mark is means we don't know exactly how to use it yet, and how the performance of certain tests are, we don't know. We don't have much confidence yet. So this is a diagram about the molecular testing. You see that specimen collected, sent to the lab. The lab will use an instrument to try to get the RNA out of the virus, and then we'll use the PCR machine to amplify, and the signal is actually labeled, detected by a probe that gave off fluorescence. So the machine will detect it and tell whether the virus is there in the specimen or not. There are a lot of specimens that could be used that we know this COVID-19 is more the respiratory tract infection. So that's like really no-brainer that to collect specimens from the upper respiratory tract means the throat or the nasopharyngeal, or lower, when we're talking about lower, would be down to the bronch or the lungs. The sputum or BL would be the specimen. But as Anthony mentioned, that in the community, is more practical to collect the upper respiratory tract samples. More used would be the nasopharyngeal swabbing, so that's NPS. So you can see that this is a swab going down, and this is the tip of the swab to collect the specimen from there. And then there's also option to get from the oropharyngeal, so that's through the mouth to collect the specimen. So there are different options when we have different swabs, and I'm not sure whether you're aware of that. There was quite a significant shortage of swabs to be used. So this is why there are a lot of work done to get specimen for the community sampling. So a lot of question about what would be the best specimen to give a higher sensitivity result. So these are the study, thankfully, to the Chinese colleagues. So they were able to compare different specimen types. So the bronch lavage or the BAL. So this is a fibrobronchoscopic breast biopsy. So these two are quite invasive methods, so it will be routinely done. And sputum also will be another way, but like they are all with concern to generalize droplets or aerosol to cause the collector to be infected. Commonly used ones, nasopharyngeal or pharyngeal throat, actually has relatively low positivity rate. So these are the questions people ask. There's a false negative. What that means, I saw some questions also. These are some of the local laboratory evidence. So this is actually one ER physician. So he was coughed into his face by a patient that's known positive. And then he actually kindly to offer help us, so to collect specimens. So March the 17th, so that's the time he was coughed on. And you can see, so this ND means not detected. So like in about 3 or 4 days, looks like there's not detected. And then we also asked him to like collect specimen differently. So this is the NPS. So that's through the nose. And then this the deep nasal swab, that's just around the nose, the nostril, and the throat, and then the nose, the nostril, and then the sputum. So we just want to see the time where the virus could be detected. So looks like the change is quite significant. So so March the 20th is not detected. And then actually 1 day later, you see that the virus could be detected both like in all the sites. So if you see the blue triangle, so that's a sputum. So we don't have much specimen. So mainly like patient with COVID-19 infection, actually they don't tend to give a lot of sputum. So that's the reason. But you can see sputum is quite a good sample. It just came out late. So again, that reflect what Anthony talked about. So it looks like actually the infection started around the upper respiratory tract, and then it might move down to the lungs. So depends on the stage of infection, different size might give you different sensitivity. Hope this makes sense. Just a summary about around the molecular testing or nucleic acid testing. We have a lot of questions asked by the physician. So I put them here, thinking might be some questions also our audience might ask already. So like say we heard patient with COVID whose first test was negative, then they were tested again a couple of days later being positive, like how this could happen. So it could be happen when the patient actually just had like early stage infection, not a lot of virus yet. And it could be the first one when the sample was collected, not a lot of material, a lot of virus taken. So that could be the reason. This like made a lot of question like to like doubt about the result and make a lot of calls between the lab and the clinical. And then there's also another question. So why don't we swab asymptomatic patients? And I think Xie talked about like some exceptions that you will test some asymptomatic patients under certain circumstances, but generally we don't. More is we are still facing some shortage, the limit of resources. And secondly, we don't know exactly the performance of the test among the asymptomatic patients. So we don't know if we have a negative result, whether that's false negative. And sometimes this false negative result might give patient a really false assurance, oh, I don't have infection, then they will run out and potentially will give the infection to the others. So this is the other question asked a lot. Then there's also a question about the sensitivity of the test. So this also go back to the first question. So it depends on like when or how you collect the sample. And also because for the nucleic acid test or PCR test, so in a normal situation, actually any test that's been used in a diagnostic lab for diagnosis will go really straight evaluation by Health Canada. It's not easy to see a test in weeks get approved. So then that means the evaluation of the test performance is different. Sometimes you use a test that probably the performance is not that great, that would actually cause the sensitivity is questionable. And so another question we also got asked about if a patient has a negative test, what should I do? So always we'll say a patient with a negative test might means this patient had an early stage infection. If the symptoms still going on, there is this risk, then you will retest in 1 or 3 days. If you remember that ER doctor's curve, you can see that just in 1 or 2 days, actually the virus would give a really different signal to be detected. And or a patient could have a negative test, but then they might be at the very end stage of infection. So that's why it's a negative test. So this would be a good example when the antibody or serologic test would be beneficial. So this would then move to the next part of my talk about serology testing or antibody testing. So it could be like really simple, like cassette test, like or called point of care test. Or it could be a really complicated instrument in the lab that can handle a lot of tubes to give antibody. Our body, when facing an infection, could it be a virus or bacteria or any other pathogens, produce antibodies. So the immune system will produce different flavor of antibodies. So IgG, IgM, IgA, like more used in, as we know them more, so they are more used in diagnosis or some immunity testing. For D&E, we don't know a lot. So just for the sake of this talk, the IgG and IgM like worked a lot, and there are more assays actually on the pipeline to be used, and there are also some testing about the IgA. Like again, so credits to colleagues in China. They've done a lot of work that make our life easier. So they have done a lot of work to show that IgM, IgA, like both for acute infection, they produce within 10 days of onset of symptoms. And then it looks like after the infection continues, it seems they are not going to be detected easily anymore, then IgG seems to kick in. Then like this is another curve to compare with the molecular testing. So that's the nucleic acid testing. This would be the antibody, and IgM is the red one, and the green one is IgG. You can see actually at early stage, you will see probably higher positivity rate using the nucleic acid testing, whereas at the later phase of the stage with the onset of the symptoms, you will see more and more antibodies could be used. So in this study, the basic conclusion is that the antibody, especially IgM, that happens at early stage of infection would be a really good supplementary part to increase the yield of detection. There's another paper actually just published yesterday, and also shows something similar. So if you see IgM, IgG, then after about 4 or 5 days, you start to see the titer coming up, and then you see more and more positive in the patient with the days of the onset of the symptoms. However, the meaning of antibody detection, as I mentioned, we are not quite sure yet. But from the study, the author mentioned that like it could be used as a complementary testing on top of the molecular testing. And this is quite in keep with the current Canadian agreement among the microbiology laboratory and also the WHO about the situation to use antibody testing. So it says it's still not suitable yet to be used as acute diagnosis for COVID-19 on itself. It could be used as a complementary for nucleic acid test, and there are a lot more we need to know about the immunity of this virus. And so it is quite exciting field, is promising. We are hoping that with more and more knowledge then we will be able to give a clear answer how to use antibody in the dealing with COVID-19 infection. But at this moment, it could be used, one potential we're talking about with our colleagues in the laboratory. So if a healthcare worker, if the IgG detect positive, that means this healthcare worker had an infection. So is lower risk to have another infection, at least so far, even though we don't know 100% whether they will reinfect, but at least means they are infected, so then they can go back to work, and especially facing the PPE shortage, some of the testing among healthcare worker would provide some information to decide and to prevent our first line colleagues get infected. So that will be the end of my talk. I hope I gave you some information about testing, and any questions, please feel free to ask.
Thank you so much, Doctor. You have given us a very informative report about different types of the testing and the pros and cons for each. I think it is really, really important to have the microbiology testing, and thanks so much for sharing. And now we're moving on to our Q&A session. I have seen there are a lot of questions raised by our passionate, enthusiastic audience, which is good. And now we will invite all the guest speakers, please, to open your microphone and waiting for our questions. And here in this session, we will, Eric and I will co-host it. So Eric, how about you start first?
Okay, sure. So my first question here is for Councillor Carol. And it says right here, how does the city inform and engage community on status of COVID to ensure access to testing?
Charlie?
I'm not sure, Councillor
Shirley
Carol?
here.
Yeah, now I can hear. Go ahead.
That's good.
Yeah.
Okay.
Yeah, it's a multi-pronged approach. Can you hear me?
Yeah.
Yes.
Okay. Yeah, it's a multi-pronged approach. It's important to note that that the criteria that you just saw is really brand new. We've been frustrated by, it sometimes feels as if the testing was much more accessible than it was. And many people thought that the problem was a shortage of nasal swabs, but you've just had the presentation that explained to you that the real shortage is the time and laboratory capacity, because it's such a complex test. So the new criteria that now exists, the approach that's being taken is to get the information. First of all, make sure that the testing centers have it, and each of the testing centers, different hospitals in the city of Toronto, for instance, are specializing in different types of patients. One hospital may be the place where most of the shelters on the east side of town are sending shelter residents. Others may be where family medicine and family practices are being encouraged to direct people. North York General, for instance, in our area is mostly coming from family medicine cooperatives. And so making sure that the new criteria is with them was the first step, so that healthcare professionals know who to direct. It's really still an active conversation as to how we might go about going out into employee groups and saying we're going to figure out ways to test you. What the municipal public officers of health are doing, Dr. Eileen Davila and others like her, Dr. Lowe and Peel, are watching is how is the hospital sector handling it? They are already right now having to deal with what happens when you take testing out of the hospital, send a crew to a long-term care home. So they're watching well that's whether or not the laboratory is able to take care of that, because part of opening up may mean testing employee groups in other fields, but let's watch how the laboratories are able to deal with the capacity issues that will be there when we're doing aggressive testing in the congregate settings like long-term care and shelter populations. A couple of hospitals just recently redeployed crews that included nurses, a doctor, and a couple of RPNs that can do the admin and paperwork of going into long-term care homes that have a lot of beds and may only have had 10 positives and 1 death. Can we stop them from having 25 deaths? So a whole crew in that setting really amps up the amount of work the laboratory capacity has to confront. We'll know in a week or two whether or not we can then go from there on to the other types of populations that Fang Li just described in the new criteria. That's why I asked the question about essential workers, because, for instance, transit workers are really anxious to be prioritized for testing before they reopen, so that they could prioritize onto the busy routes those who may show that they have antibodies or have already been through this. Then could we put them on the busy routes where distancing is going to become very difficult when we reopen? We're looking at those types of things.
Yeah, that's a great point. Thank you for sharing.
Thank you, Sherry. And our next question is for Dr. Bai. Dr. Bai, are you still there?
I'm here.
Okay, so it's a very interesting question. It said we have hold a press conference in China that they recommend to use Chinese traditional medicine. They said about 20% of the Chinese patients are recovered because of that. So how do you think about this? And will Canada or Canadian doctor will adopt or kind of use the Chinese traditional medicine in the treatment here?
I just want to say that it'll be nice to see the evidence first before recommending the Chinese traditional medicine. I find I'm more open-minded. Whatever works, if it's proven to work, I'm happy to apply it.
Yeah, thank you. 那么我们关于这个中医的问题呢，我觉得我们的白医生也给我们解答了。我们首先还是要尊重科学，如果我们有了很 concrete 的这些 evidence， 我们是可以考虑，是吧？好的，Eric.
Right here, I have a question for Dr. Yu, and it says, how much does the RT-PCR cost for testing one person?
Just brief to say that there's no charge for individuals, but the test itself depends on different kit to be used. So some labs have a laboratory developed test. That means they can use some reagents and then their own primers or probes. Actually, that's around $20, and depends also on the volume, right? And in Canada right now, the expense for testing is not a big issue. But the reason why there is a limit of testing capacity is all related from the swabs. So swabs, we have been using Italian company produced swabs. And because of the demand and also because of the situation in Italy, the whole chain of the supply basically broken. So that's why the swab is a big issue. And then the laboratory actually has been really creative to validate different alternative swabs to deal with it. So that's why, like when I show you that ER doctor's swab actually is different alternative swabs has been used. So the reagents, same thing. So we are using a couple of big companies' reagents, and then with global needs and with transport as issue, everything as a make it so challenging to have a test. Like for myself, I have been keep validating different alternative assays to be prepared. So like everyone in the lab has been working hard to get Canadian the best opportunity to test.
Thank you so much. 下面这个问题可能要请教我们的这个谢女士。我们看到我们的群友里边，就是我们的这个观众群里边，不仅仅有我们 Torontonian， 不仅仅有我们 Ontario， 还有一个网友 from BC。那么他也关心的就是，他知道这个 BC 省的 Dr. Henry 每天都是定时更新这个 update 的，不知道我们这个安省的卫生官员是不是也是这样做的？
安省的卫生官员哈是 initially they provided daily update, but I'm not aware now they're doing daily update. So, but you can still check the case status from the Ontario.ca COVID-19 website. You can also most update information from your local public health website. But I'm not aware of the daily update, the news update from Ontario public health officials. Yeah. And also I want to address the question about essential workers. I think I shall ask the question. Yeah. So for essential workers, this categories was added to the April 15 guidance document. So I provide the website. The transportation workers are included under that new guidance document. But I don't see many people currently tested from that essential worker categories. I think we'll pick up slowly over time. Yeah.
Okay. Eric, do you have any other questions?
I have another question for Shelley. It says right here, so how do we prepare for the reopening of Toronto? You mentioned that when this pandemic subsides, when it comes to much lower numbers, that the reopening of Toronto is going to be a lot more different. It's going to be a lot more critical on its safety. So can you give me some? Could you give us some ideas on how or details on how this will be like, and how to prepare for its reopening?
Well, one of the things that's being looked at now, we know for sure that people will be more confident about a re-entry into public life if they know that masks, that for certain activities you could require them of anyone who knows that they may have been exposed. There'll be places where you want people to wear them. If you're coming into an ER because you have any kind of respiratory symptoms, it's natural to assume that between now and a year from now when we have the vaccine, if we touch wood, if we have the vaccine, that you might want people to wear masks in all sorts of places. So they're already working on what can we require based on supply in Canada that would give people comfort. You might want to, today you may have seen on the news that a private sector grocery store owned by Loblaws experimented with announcing today that they're going to advertise that all of their employees have their temperature taken every day by a non-contact laser thermometer, and that customers have the option of having their temperature taken as they go in. If that doesn't explode in an uproar, that's an invasion of my privacy, and it didn't. People actually received that idea very well. It's logical to assume that they're going to start to ask policymakers to make that policy. Why don't we require that, at least for the next 6 months? What are the supply issues of all of those types of policy decisions? So all those things are being looked at right now. What's also being looked at, though, are the things like programs that we ran before. What can we start back up? If we can't, for instance, have summer camp, what does that mean for children's services? If we're going to go through a whole summer where we're saying you can now return to work, we need to kickstart our economy but we don't want kids in group settings until September. We've got to deal with those issues as well. If we don't want to have special events, things like that, what are the mental health ramifications? Employment has to begin, and we need to start to robustly look at our people who've lost jobs able to become a part of a COVID effort that will continue on in social development and social services for some time. And how do we find that? And how do we do the recruitment safely? Those are all the active conversations that are going on right now. So there's the medical supply side and the public comfort with the safety regulation side, and both are being looked at. But it's, as you heard described in terms of a lot of it is like the testing dilemmas. Most of it is supply chain. We know what we'd like to implement. People have said from the beginning, can you require everyone to wear a mask? We can't if you can't buy a mask for love nor money anywhere in town. We know, though, that we're soon going to get to the point producers are working as fast as they can. We will soon be just the same way things are cash register. Until we don't have that kind of supply in the general market, we can hardly say to people, we'd like you to wear a mask on the TTC. So they're trying to get enough intel to know what they can require and what they can implement about a month from now. Yeah.
Thank you for that.
Thank you so much. And the next question will be for the Miss Xie. 有一位这个观众朋友问呢，就是如果他是一个轻症患者，轻症的阳性患者，什么是一个对他来讲最好的这个策略？比如说他现在真的检查出来阳性，但是可能还没有特别明显的症状，因为我们加拿大没有方舱医院嘛，现在，所以只有10%的人能住院。那么他们自己在家自愈，这种是最好的方式吗？我们怎么才能帮助这些人更好的治疗？
就是，目前为止呢，那个轻症的病人是送回家治疗的，就是自愈的啊，因为这个病毒本身没有那个治疗的方法，就像那个医生提到的，所以呢，即使你想住院，医院也不会让你住。医院会把你送回家，所以大概就是说，大概10%的人，他有就是满足这个住院条件，他才能够去住院。我觉得这个理由呢，是因为怕医院 get overburdened， 所以医院他会所有的人如果都涌向医院的话，医院就是会这个系统会受不了，所以他是基于这个 rationale。因为我们现在公共卫生看到的，像我们区住院率只有8%的人住院，其他部分都是就是回家。送回家，然后呢，公共卫生的护士他会每天打电话监测，询问你的症状，如果有加重的情况下呢，他会安排你住院的。所以这个有很多时候是不是你能选择的，是根据你的病情，就说你即使想住院，他也不会说你可以住院。我不知道会不会
做一个尽快的补充。实际我觉得适合于加拿大的国情。中国的建方舱医院，特别在大城市里边，因为它是都住 apartment， 在家里隔离呢，会影响家人很大。加拿大的总体来讲都是环境比较好，空间比较大，所以呢有这种条件可以在家里做。另外呢，加拿大从资源来方面、管理方面不如中国那边这个更严格一些，所以呢，在家里是最实际也是可行的一个办法。
好的，谢谢王教授的补充。那么这里边可能这个问题还得接着请教您。有一位网友问呢，这个英国的论文给我们的 COVID-19 分了 A、B、C 3 types。那么加拿大确诊的时候是否有分型，哪一种更严重，就是说更高的几率得这个重症啊？是不是要等到多届这个疫苗的出来，单届的好不好？
现在来讲还没有这个分型。现在 A、B、C 型，它根据这个遗传特征，就是因为它遗传主型，然后我们说野生型最初从哪来的，然后它分型。这个来讲呢，现在检测当中没有包括这个，可能杨医生更知道一些，更比我了解一些。现在只是限于科研这个阶段，前面那个报的这个 sample size 以前报的也并不是很大。所以现在流行这么多人，现在的分型如何，我并不是特别清楚。 至于这个分型是不是跟这个疾病的 prognosis 它的这个预后有相关系，我这点没有任何的这个资料，我没看到任何资料。可能呢，到通尼白呢，可能也许有相关的信息，我相信呢应该没有相关的 research， 如果有更好。
So Dr. Bai, do you have any kind of thing to more add about the types of the COVID-19 ABC?
No,
Do you have read any
so
research?
我也不知道，因为我们在做 testing 的时候，我们不知道是 A 或者 B 或者 C， 我只知道它是 COVID-19 或者 not COVID-19。
OK， 那我们可能还是需要这个研究，还是要继续的。我相信这个 COVID-19 对于我们现在所有医疗界的，不管是研究人员还是临床人员，都是很新的问题。我们的研究还在持续的进行过程当中，所以大家也可以继续保持我们这个关注。OK, Eric, do you have any more questions?
I have one for Dr. Yu if we have time. Yeah, we do have time.
Yeah.
I have a question. The current status of the Spartan testing cube manufactured by the Canadian company, the Spartan testing cube.
All right, yeah, so I think people might be interested is in the news. So just a quick words about the ABC. So that's basically like only in research when you do whole genome sequence of the virus, then you will know. The current one only testing the segment, so you won't know exactly. Then go back to the question of Spartan, and also people ask about 5 minutes testing in the States, like are we going to have something like that? Yes, so Spartan is a similar idea. So that's the idea of molecular testing gave a rapid result, because if you look at the laboratory nucleic acid testing right now, from the specimen to arrive in the lab, you need to get the RNA out, extraction, and then you do the testing. The time needs would be around 4 hours or even more. And Spartan is a quick test. We don't know how the performance yet. So right now in the couple of hospital sites are doing the evaluation. So far, there's still some questions about its performance. So first of all, the sampling might be a question. So use a different type of like a little plastic spatula. That's actually more for the genetic testing. So that's the whole device actually invented at the very beginning. So used now for COVID-19. So secondly, whether this means truly positive or false positive or miss some, we need to have parallel laboratory is still quite premature to say that, but that's a good idea. And that will be something hopefully States. And then go back to that question about 5 minutes in the States. There is this molecular testing, but unfortunately the company won't be able to have any available to the Canadian community yet.
Right.
Yeah.
Okay.
Thank
So
you.
next question will be for Shelley. It is also regarding to the Chinese traditional medicine, because in China, the CDC in China have in their official website said there are over 70,000 cases, successful cases with the treatment by the traditional Chinese medicine. So in Canada, do we have to offer what kind of supportive material or what kind of supportive evidence to promote the Chinese medicine here adopted in Canada case, especially from the perspective of government?
Well, it's really important for people to understand, and this will be a comfort to everyone on the panel here, especially Dr. Bai. When it comes to policy making, that is where I can honestly say that once you're in a crisis mode like this, there's far less partisanship. So while it would be nice to say, I'm going to grab a brand new base of voting by endorsing this, and being the first person to say we're going to adopt guidelines to say that we endorse licensing or whatever around this. We're going to err on the side of science on this. If there isn't enough evidence yet in the medical profession to say this is a solution, then you're not going to hear it from government and policymakers. When we're facing, a death count every day, we're not going to stick our necks out because it would make political points. We're going to go with the evidence. And you've already heard Dr. Tony, if you don't mind my saying, say, I need to see the proof. The same reason that he needs to see proof from the data that we're looking at in Western science, we would need to see it in the same sort of control group settings to have confidence in those types of medicines. And it just isn't there yet. And so, people might take comfort from it, but we can't endorse it as a solution and say, if you haven't already adopted this, you must. We can't politically wade into that territory. We have to follow the science. And I can honestly say, there are people in leadership positions right now who I always agree with, or sometimes agree with, and never agree with. We have leaders in all of those categories. All of them, I've seen evidence that they are relying every day. Doug Ford is relying on Dr. Williams and Barbara Yaffe. Justin Trudeau is following Dr. Tam's lead. Dr. Davila is everything in City Hall right now. And that's what you want your policymakers and politicians doing at a time like this. It's part of the reason that you see the struggles around how to go back to meeting as governments, because when you're in a state of emergency, you give the leader all the power, and he keeps in touch with us. So he's not going to abuse the power that he has, nor would Doug. Doug's still meeting with his cabinet. So is Justin. But when we go to have our council meeting and they open their House of Commons, you saw them debate that all day today federally, you lose a little bit of control of that doing what the doctor says. And so we will probably open our government up to begin to debate things at the end of April, and the federal government will do so around the same time. But you'll see us putting really strict limits on what we debate, so that for as long as we can in the COVID crisis, the doctor has more power than the politicians.
Good to hear that, and we really respect that our government, our medical regulators could consider the balance between ensuring the safety and effectiveness of the medical device or medical solutions. So just for the best for most of us. So thank you so much, Shelley.
Yes.
Mm-hmm. And for the ECMO, I think Dr. Bai have already answered. Okay. So do we have any more questions? We only have limited
I think we're coming up on 10:30. Yeah.
Okay,
yeah.
I will leave the last question for you.
Can I ask one question?
Yeah.
Okay. Yeah. I want to thank everyone, especially the guests and our counselor. Ask a counselor one question. So I know you're from Toronto area, so I see a lot of people living in other regions like York region or Peel region. So when they come down to the corporation, all the counselors or even mayors, they talk about how they cooperate. For example, then reopening for business, how that goes. Counselor?
Yes. Yeah. In terms of opening things up for business, there is some evaluation going on right now about if we have to get businesses and employees of businesses, most importantly, if we have to get them through the entire month of May, what does that look like? Because most of the reliefs and supports were really about getting people through April, and now we know we're headed towards May 1st. which is not just rent for people, but commercial rents, which no one has really offered relief from. And so there is some concern there. So we would like to open up as soon as possible, but we know that given that we're just now getting to the peak and the flat part of the curve, that you really want a couple of incubation periods afterwards. So we know we have to make do probably for most of the month of May. And that being the case, we are already setting up roundtables with businesses to talk about in the various sectors that are most prominent in Toronto's economy and really the GTHA economy. We're gathering roundtables to talk about what are the challenges for you if you're open for business. Things that we've already heard are the businesses with a lot of public interface. How do they get open? The biggest concern is how do we get back to where people can go to restaurants and there's a feeling of confidence. We've always had a great deal of confidence in Toronto's restaurant inspection system and replicated throughout the GTHA and the rest of Ontario over the last few years. But how do we get back to what if there is anything that we need to require there, or if there are limitations on the number of people in a place? We're going to have roundtables. They actually started last week and will continue on for the next couple of weeks so that we can gather as much information as possible and then begin to develop guidelines. But for most businesses, they will be voluntary guidelines because we have to be honest. We won't have the capacity as we open back up. We're a government right now because we don't have income tax. So while there's consumerism still going on, we're losing $65 million a week as a government in the city. So we won't have a lot of extra resources. Yeah, it's a big number. Between transit and other types of inputs into the city that aren't coming, it's $65 million a week.
Wow.
And so we'll be $1.5 billion out if we go to the end of the month of May. So a lot of what we're going to recommend to businesses as we say go ahead and open up, whether it's be it June or whenever, will be these are guidelines and they're largely going to be voluntary. And what we will have on hand for people is advice and bylaw officials that can help you set up a safe environment, and there will be incentives to do that safe COVID preventative environment, because we got to be honest, we're not going to be able to continue on the level of enforcement that we're right now doing, where because people are staying at home, our police are doing nothing but COVID misbehavior prevention, and bylaw officers are racing around checking to make sure businesses aren't open because of COVID. If we open back up, they will have all their other responsibilities come back. So what we'll probably end up having is a long list of voluntary guidelines that meet each sector, and we'll also be relying on the other orders of government to decide what happens to travel for the businesses that are all about, whether they're about tourism or hospitality, or if they're businesses that just rely on a certain amount of global travel to get their business done. We'll need a lot of guidelines that will come from the federal way to kickstart the economy again.
So thank you. Yeah, really good answer. Yeah, thank you.
Thank you so much. Thank you so much for all our 5 guest speakers. Great sharing, and especially for the Councillor Carol. And thank you so much for explaining the policy to us, that to understand the government, how the government work, and how we could coordinate with the government to let everyone on the same page. I think it is not only the government's responsibility to protect us, it is all of us' responsibility to protect us. So thank you so much, and all the professional expertise to share a very informative thing for us to clear up a lot of the misunderstanding, misinformations, misinterpretation. So I think this is really, really great event. And my special guest, my special thanks to all the audience. And I have seen a lot of great questions has raised, has inspired each of us. And because we don't have a lot of time, due to the limited time, but we will collect all the questions that are unanswered, and we will send to the professions, ask them. Hopefully they will answer them, and we will organize. And I think Professor Wang will update it their website or their WeChat account so people can follow. So is that possible, Professor Wang? You can share the slides. So your WeChat account and the website.
That's good. Yeah, we are going to do that, and I'm very glad to see so much enthusiastic response from the group, and particularly from the audience. Yeah, this is very successful, and I think we should do this again before long. Yeah, good.
Okay. Yeah, we should learn every day. It is very new thing.
Okay.
Yeah.
So Maggie, I just want to take this chance to thank Counselor Shirley again, Dr. Bai, Dr. Yu, Ms. Xie, and definitely Professor Wang. Also, all the volunteers, including yourself and Eric as a host. And the last, I want to say again, take this opportunity, let's fight together against COVID. Also, I want to ask everybody, we can work together to help the community, to support the community. Also, for the very, the concrete step, if it's possible, you can donate through this, Canadian Red Cross. CCA work together with Red Cross. Now you can donate, you can get your tax receipt. I think at the end of it, before the end of this month, if you donate $100, actually another company are going to give you $200 to match. So in total, you actually donate $300 to the Canadian Red Cross. And the Red Cross, I think they commit for this kind of money, they're going to put into the COVID-19, the disease fighting. So that will be very good opportunity for everyone to contribute. Definitely protect yourself well, protect your family well, then we all together, and I think we can win this battle. Thank you very much.
Okay, thank you all.
You bet.
Thank you.
Thank you everyone for coming.
It's already very late, and